Okay, hey, today is a great privilege to have Dr. Joshua Bess with me. And Dr. Bess is with Seattle NTC, and he's also happens to be my doctor. And he's fantastic. He's a leader in the field of transcranial magnetic stimulation, which we'll talk about today. And he also performs ECT for patients that benefit most from that. So thank you, Dr. Bess.
Thank you for having me, Bob.
Yeah, appreciate it. So basically, who is a good candidate for TMS, for transcranial magnetic stimulation? Is it people who are med resistant to depression, or what would be a good candidate?
We think about two categories of people. One is people who have tried lots of meds. Some people 12, 15, 20 different medications.
Wow.
And then there are also people who, for whatever reason, don't tolerate the medications. So maybe they haven't had a chance to have a complete medication trial because it causes side effects that just aren't ones they can live with.
Yeah.
And so usually various insurance companies will allow us to try TMS in either of those cases as long as the different criteria have been met.
Okay. So basically somebody would have to have tried meds for their depression before they could get started.
To get it covered by insurance.
In order to get it covered.
Right.
Okay. I know that you have a form that asks questions like, are you sad? And then it scores 0 meaning never.
Right.
And then 3 meaning every day. And when I first came in, before I did TMS, the acute treatment, the treatment where you get 35 treatments in a row, Monday through Friday, when I came in, I was scoring a 3 on everything. I mean, every day, I felt sad, and every question, I just was like, holy crap, I'm scoring 3 on all of these. And I remember going through the acute phase of the treatment, and it literally would move from 3s to 2s, and then like a week later it went from 2s to 1s, and then at the end of it was all 0s.
Yeah.
And I never felt better. Since I've been diagnosed and treated, nothing is delivered like that has. Yeah. And now I'm on, as you know, a maintenance dose because I just want to continue that good feeling. And when I start to see my numbers start to go towards the 3s, I know I need a little bit more help.
Right.
So what do you see as the efficacy? Do you see, if you can just elaborate on that?
I'm glad you brought up the scales. That's an important part, although far from the only part of the things that we look for. So you're talking about what we call the PHQ-9.
Right.
It was a depression questionnaire developed several years ago as a screening questionnaire, but now we also use it to follow people through a course of treatment. And so when you first came in, a score of mostly 3s or all 3s is severe depression. And again, as far as the insurance companies go, that's also a way for them to verify that you have severe depression in order for them to authorize the TMS.
Okay.
And you described what we often see, which is the score week by week gradually decreases. In your case, all the way to 0, which is great. That means full remission, so the opposite end of that spectrum. There are some people whose score decreases, very meaningfully, and they feel better, but not quite to 0.
Okay.
Those patients could be considered people who respond but don't necessarily remit.
Okay.
And so when they do the studies on various treatment modalities, usually there's a statistic for the proportion of patients who reach remission, like you did, and the proportion of patients who are responders or have a response, which is still important.
Yeah. Because they got better.
That's right. Yeah. How I explain it to people, because that can be a little bit abstract, even though it's a number, but the idea of having a response, I think, is at the end of the treatment course, every day for 6 weeks is a lot. Do you feel like it was worth it?
Yeah. Oh, I see.
Do you feel like the travel and Seattle traffic and
Yeah,
and the
right.
effort and the time and in some cases the money, do you feel like that your improvement was enough to make that worth all of the hassle?
Mhm.
I consider that a response. You know, if I were doing a study, we'd have to be a little bit more exact.
Sure.
Yeah.
Yeah. No, that is good. The results are good.
Yeah, absolutely.
Um, does it like I think about it as unclogging,
Mhm.
you know, the nerves that deliver these great ingredients like neuro. Help me with that one.
Norepinephrine.
Norepinephrine, thank you, and dopamine. These are enzymes or chemicals that
Transmitters, yeah.
transmitters that are very good for battling depression.
Right.
These are our mood enhancers,
Mhm.
and I think about them just being clogged. Like if a neurotransmitter was the UPS truck, and it was going to my house, which is the receptor cell for all Amazon, that I would that somewhere along the road there's a clog, there's a backup. The truck can't get through, and I always felt like when I had the procedure that the clogging got taken away.
Yeah.
Is that I know that's just a silly way for me as a metaphor, but what do you think?
You know, there are lots of metaphors that people have tried to come up with to explain exactly what happens. The truth is that, you know, in some cases we don't know exactly what happens, and there are some theories about why it might work.
Okay.
I think the unclogging metaphor is great. I think
okay.
if you picture the UPS truck trying to deliver those packages to your house,
Yeah.
anything that will enhance its ability to get there faster or to deliver more packages,
Yeah.
if that's what we're looking for,
Right.
is a good thing. Maybe one that would be a little bit more true to life as far as what's happening would be that the TMS is also creating alternate routes. So one thing that we know about brains, even in people who have been done growing for a long time,
Yeah.
is that your brain can still change. You can still form new connections or even pare back connections that aren't useful. And so one of the things that these brain stimulation treatments, including TMS, do is encourage that. They encourage the neurons to form new connections that, if on balance they're useful ones, they can be helpful. And so maybe the UPS driver has a device that allows him or her to go around the traffic or go around the clog, right? So, you know,
He's using his ways.
That's right.
Around,
And so we're always looking for new information about how it actually works, because there's lots of times when we know what it does and we know that it works, but it's hard to connect those two sometimes. We don't know that doing that is why it works.
Okay.
Yeah.
No, I never knew about that. I've studied some of the neuroplasticity
exactly.
research out there.
That's one of the big buzzwords, yeah.
Yeah, and that's going on with
Yep, we're taking advantage of that ability. That's
I like the rerouting analogy.
Yeah.
Yeah.
More connections.
More connections, so all of my packages can show up.
That's right. The credit card is a separate issue.
Yeah, well, let's talk about that another time. Now, I was going to ask you where it's performed. Now, I know because I've been here many times, but it's in an office setting. It's non-invasive.
Right.
I'm alert and awake. It's like sitting in a dentist chair with the benefit of there is no dentist coming. and I just sit there with my laptop, play games or do whatever I want to do. You give us earphones. Mm-hmm. So I can listen to music as well or watch a movie is sometimes what I do. Is that generally where it is performed in a clinical setting?
It's almost always in the United States, at least, almost always in an office setting.
Okay.
And there's some practitioners who have TMS devices in hospital settings, and especially in research settings that happens. But the vast majority of the treatments are performed in what is otherwise just a regular psychiatric clinic or an office.
Wow.
And we're in this is our Bellevue office, and there's nothing special about this office building that makes it medical or anything
Well, it's not
for that
even a
matter.
clinical building,
No,
is it?
and so, we just need to upgrade the electricity, that's all. But otherwise, it is a very just sort of non-invasive, safe, relatively benign procedure. We have patients wear ear protection, so the earbuds you're using are noise canceling.
Right.
Or you can just wear regular earplugs. And yeah, as long as you're able to, depending on the device that's being used, as long as you're able to hold your head still,
Right.
you can read or watch something or listen to something. People do a lot of different things.
Right, right. That's very interesting. What it is there's a magnet. To me, it looks like Disney mouse ears.
Yeah.
And it just leans on your head. You wear a goofy-looking white cap, which I do have a picture of me, but I'm not going to show anybody yet. And you and it just rests on your head, and that's one of the reasons why you just can't move your head around, because you're going to be moving it from the mark it needs to be on. And then it does make a little bit of noise, but I learned, the first few treatments that kept me pretty alert in a way. But then subsequent treatments, it was very soothing for whatever reason. It put me to sleep. My biggest challenge doing TMS is not falling asleep and nodding my head on the poor technician and her having to wake me up and be embarrassed. That's about the hardest part of the treatment, is that I fall asleep during it.
Which is pretty remarkable, thinking about how maybe uncomfortable it was the very first time.
It was very uncomfortable the first time.
But people get used to it really quickly.
That's common, isn't it?
Yeah. I joke with patients that the only thing we can't let you do is sleep.
Right.
And that, of course, if you nod off, we're not getting the good contact with the magnet, but also, a study showed that it doesn't work as well if people are allowed to sleep.
Oh, okay.
You need your brain to be awake and active.
Okay.
Yeah.
All right.
So the staff is trained to poke you awake.
To poke me, yeah, they do.
Yeah.
They do. And after being shamed a couple of times, I'm usually pretty good. Now, are there other modalities that Seattle NTC performs that you do besides TMS?
Yeah, so, we are specialists in what we call brain stimulation.
Oh, stimulation, okay.
There are a couple of other terms that people use: neuromodulation, neurostimulation. They're all terms of art, but we like brain stimulation. And so TMS is a big one. ECT, electroconvulsive therapy, which has been around since the 1930s, is the other main part of our practice and what we do. Okay. That is performed at the hospital under anesthesia, and it's a very safe procedure as well, but there's a lot of extra things that go along with that. And then we also have people who have had VNS, or vagus nerve stimulators, implanted, where there's a battery, kind of like a pacemaker, and then a wire that hooks up to a nerve in your neck. And that is able to send signals back up to your brain in order to affect mood. And so that was approved about 12 years ago, and is being kind of resurrected now as a more available, effective treatment, because we've gotten some longer-term study data that shows that it can be really helpful over time.
Okay. So is it surgically implanted?
Right. Okay. So a surgeon implants the battery pack and the wire into your neck. Okay. And then about 2 weeks after the surgery, you come into the office here, and we have a programmer that allows us to change settings and adjust the frequency and the output and things like that. It's a technology that's been used for quite a while with epilepsy and for seizure control.
I thought I've heard of it
before. And so then it was studied in depression. After that that technique was perfected, it was studied in depression, and so we've sort of piggybacked onto the work that's been done in epilepsy.
Nice.
Yeah. And we actually have patients who have another type of implant, DBS, deep brain stimulator implants, for OCD. So the FDA allows us to, the neurosurgeon, to implant deep brain stimulator electrodes in the brain. Wow. And if they put them in a certain spot, it can be helpful in OCD. Wow. It's been studied as well for depression, and there's a new study getting started, which we hope to be part of. studying that for depression. But that technology was initially used for tremor, essential tremor, and for Parkinson's.
Oh,
And then people observed that it had some effect on mood, and a couple of really very talented, very smart researchers in Atlanta and in Toronto and other places in Houston have been working on that.
Oh, cool.
But we have some of those patients who have gotten it for OCD.
And that would be in a severe?
Very
OCD?
severe, yeah. It's pretty much...
Just pretty much.
I don't use the term last resort usually, except for in that case. Usually for OCD, either the EVS implantation or actually brain surgery can be effective too.
Okay.
Those are the last resort.
Okay. Great. Wow, that sounds great. I was worried about having brain surgery and the doctor waking me up later and saying we just couldn't find it. I'm like, I told you.
Well, I've told, I think I told a friend of yours that the advantage, one advantage of TMS even, is that by clicking on the right spot and we make your hand or thumb twitch, we prove that your brain is there.
I know.
So
I did prove.
you can go around and just show people that that's
Well, my son knew, and I was like, well, I'm connected.
You're connected somehow. Like you couldn't.
Don't ask my 10th grade biology.
That's right.
And the last thing I was going to ask you about is, because I do have a friend that introduced me to you, and I know others have had ECT and didn't get the benefit, but they got the benefit of TMS, like this friend of mine had a lot of ECT, but then his whole world changed when he had TMS. Could you just talk a little bit about that, about why that might be?
Yeah, and that definitely falls into the category of things that we don't exactly understand, but we observe frequently.
Okay.
And when TMS was being developed, it just so happened that a lot of the people who were initially involved, and when it was first approved, a lot of the people who were initially performing the treatment were also ECT providers. They kind of go together.
Brain stimulation, brain stimulation.
Right. And so there was a tendency, in a sort of broad way to think of it as ECT light. It was like ECT, but without the side effects, without the anesthesia. It's more sophisticated than that, and it's more complicated, and they work in different ways, even when the final result is the same. And so what we've observed, and then are trying to continue to understand, is more classically, people try TMS first, and it doesn't work quite as often as ECT. And so if that doesn't work, then they go on to ECT, and many of them have a response. But people like your friend, and we've had dozens of them who tried ECT and it might work part way or might not work at all, and then they go to TMS and have a very good response. And so early on, that was a bit of a head scratcher.
Because it's the light version.
Right, we thought of ECT as this intensive kind of big treatment. It just so happens that there's a difference in the brains that we don't understand yet, and that treatment matching is what we call it. Picking the right treatment for the right patient is really a big deal, and there's a lot of research going into that, and it's something that we need to understand better, because we could get people relief much faster. We could save a lot of resources, save a lot of money for the system if we weren't doing the treatments that weren't going to work. And so people are looking for biomarkers, whether that's a blood test or an EEG signal. We're involved in a study right now along with Stanford University where we're doing EEGs on patients before they start TMS, and afterward we're going to try to see if there's a way to predict perhaps who's going to be a responder. That's a really hot thing right now, is trying to figure out if there's a way to tell whether someone will respond, because then you can go right for a treatment that would work.
Right, you can just back up into
That's right, yeah. We even have a few people, maybe a half dozen or so, who have done both at the same time. So they'll be getting ECT, and as we decrease the frequency of the ECT, they start to relapse, or they're having bad side effects of ECT, and so then we'll add in TMS on the days that they don't have ECT to try to support that mood and try to get them through the rest of the ECT and be able to reduce it because it causes more side effects. Perfectly safe. We've written up a couple of those cases, and I think there's going to be more knowledge that we find with that too, how we could potentially use both in certain situations.
Oh man, that's great. There's good stuff going on with it.
Yeah.
Well, how
would somebody find out more? They can certainly look on the website for Seattle NTC.
Right.
What is the website?
SeattleNTC.com.
Seattle
NTC Neuropsychiatric Treatment Center.
Okay.
There are general websites about TMS. I always point people toward the Mayo Clinic website about any medical information because they have really good information that they then can lead you to the next place if you want. The Clinical TMS Society at CTMSS, I'm not sure exactly what the website is, but Clinical TMS Society has a good patient portal and various ways you can find practitioners in the area.
That's what I was going to ask you next. This will be viewed by people around the country.
Sure.
And hopefully sometime around the world.
Yeah.
And we know that this is done in other countries as well.
Yeah.
So the best thing to do is go on whatever internet service
Right.
might have and search for practitioners.
Yeah.
It seems to me that there are more practitioners opening up TMS offices.
Yeah. Yeah, that's been more widely adopted by insurance companies, and as the word gets out, and I think the work that's being done against the stigma of depression,
Yes.
people are more willing to ask for help or to ask what the options are. And they're searching the internet, right? So I think that there's a long way to go. There's still a lot of people suffering who aren't getting help. And so, I'm happy to see more people getting access to treatment. I mean, I'm only one person. I can only do so much. We really take good care of people, but we're pleased to have colleagues and other people to share that responsibility with because there's a lot of people out there who need help.
Yeah. Well, I appreciate the help you've given me, and I would encourage anybody who's struggling with their depression, bipolar depression, that has tried a lot of meds. I've been through probably 20 different psychotropic drugs myself, and still struggling with their depression to really look hard into this. It's been a life changer for me, for this friend of mine, and for I know countless others. So thank you for your good work. Appreciate it.
You're welcome.
Thank you for letting me do this with you.
Yeah, thank you. Appreciate it.